Thank you also very much for joining the call. My name is Foyeke Adebago, and I work out of the USAID Health Population and Nutrition Office as a program manager for social behavior change. It's really a pleasure to have you join this webinar, and we're particularly very pleased that you're able to make the time. We will kick it off now. My task is to really start us up and sort of set the stage and shape the expectations as to what we will cover today very broadly, introduce our presenters, and then some general housekeeping rules, and then I'll hand it over to our first panelist. So today we are, this is one of a series of webinars organized by Breakthrough Action and Breakthrough Research. Both activities or projects are USAID funded and implementing SBC interventions in Nigeria, as well as running research and evaluation type activities for social behavior change in Nigeria as well. So we'll learn more about both mechanisms and how they work together to continue to collect evidence and use that to inform programming. Today's webinar series webinar is focused on specifically on looking at insights from a behavioral sentinel survey that was run in September 2019. We'll learn a lot more about the methodology of that survey as well. And then our presenters will walk us through findings related to family planning outcomes and behaviors, and the statistical relationship between several ideational factors, or what we call determinants of family planning behaviors. Thank you again for joining. Our presenters for today would be Dele Abegunde. Dele Abegunde is the Chief of Party for Breakthrough Research Nigeria, and he's with the POP Council, which is the lead implementer for the Breakthrough Research project in Nigeria and globally as well. Our second panelist, and we're hoping is able to join us shortly, I think he might be having technical challenges, is Shitu Abdu Aguye, who is the Deputy Project Director for Integrated SBC on the Breakthrough Action Nigeria program. He's with the Johns Hopkins Center for Communication Programs. That's the lead implementing partner on that project as well. And finally, we have Paul Hutchinson, who is with the Tulane University, and he is one of the principal investigators for the Behavioral Sentinel Survey that we'll be learning more about. And Tulane is one of the partners within the Breakthrough Research Consortium. So in terms of general housekeeping, we would really appreciate if you, keep the, do not wait till the end of the presentation, but really keep the questions coming in the chat box or in the Q&A. So you can either use the chat box or you can use the Q&A section. We would, as much as possible, try to manage our time to be able to get to them. But there will also be someone on the team who is looking at those questions and trying to respond to them in real time, so that we have less, we would spend less time on the actual Q&A section. So that way we're sort of efficient with our time. So I would hand it over now to Dele, who I think would launch us into the actual presentation of today. Over to you, Dele.
Okay, thank you, Foyeke. Always great to collaborate with you on this presentation. I want to welcome everyone also that is joining us to listen to our presentation on family planning and SBC in northwestern Nigeria. My name is Dele Abegunde. I'm the Chief of Party. And I will start a little bit with the presentation, but the person to listen to today is Paul Hutchinson, one of our principal investigators who is driving all of this research with Paul Hewitt behind the scene. And then I have Emily Johansson, who is the Deputy Chief of Party and the manager of the engine room that is crunching all the data with many other scientists in Tulane, in Washington, and then in Nigeria, and also Udo Anaba, who is a research coordinator. They will be in the background answering your questions as we go on. So today we are going to be discussing the psychosocial influences on modern contraceptive use in Sokoto, Kebbi, and Zamfara states. Next slide, please. Just an overview of the webinar today. First, we are going to be sharing with you briefly about breakthrough research and probably give you a little bit of breakthrough action also that we work collaboratively with. We will be asking the question, what is the behavioral sentinel surveillance survey, the BSS survey, and everybody say BSS. We will be elucidating that. And our focus will be on family planning in today's webinar. And we'll be looking at how did formative research inform the BSS survey, and also the new ideational metrics that is coming on and what they tell us on the field. We'll be sharing key BSS findings from these 3 states in northwestern Nigeria, and also the implications for SBC programming, particularly breakthrough action programming on the field, but the implications for programming generally in Nigeria. And then we will share what the future work is. What are we focusing on for the future? Next slide, please. Now, just a little bit about breakthrough research. Breakthrough Years Research is a USAID's flagship project for social and behavioral change, research, and evaluation. It's a 5-year project which began in August 2017 and is going to end in July 2022. But the breakthrough research activity began in January 2019. We set up the office to hit the ground running in September 2019. We are in close collaboration with the sister project, like I mentioned, the Breakthrough Action and other IP. Breakthrough Action is involved in program implementation in many states of the Federation. We'll get to see it. Next slide, please. Regarding Breakthrough Action, also is a USAID flagship project for social and behavioral change. And in Nigeria, the present in Nigeria, the overall result that is expected from the activities to increase the practice of 17 priority health behaviors in the areas of maternal, newborn, and child health, plus nutrition, and then family planning and malaria. The intermediate results that they hope to achieve improve individual and social determinants of health, strengthen SBC collaboration, coordination amongst USG partners, and strengthen SBC capacity of national and subnational public sector entities. Next slide, please. The priority behaviors are laid down here. They're a little bit tiny, but it's in the area of pregnancy, the continuum of pre-pregnancy, pregnancy, childbirth, first 6 months, 6 months to 24 months, and then 2 to 5 years. This is the scope in which also the BSS research covers in bringing out evidence, programmatic evidence to support BA as they run their program. And they will have a list of things under each segment of the continuum, which will I will encourage us that we look at those when we assess the presentation materials. It includes use of modern contraceptive method, for instance, in pre-pregnancy period, and attendance to antenatal care during pregnancy, attendance to health facility for delivery, and so on. Exclusive breastfeeding and immediate breastfeeding, adequate feeding in the infant age and up to 2 years. So these are some of the spectrum of issues that breakthrough action is looking into on the field. Next slide, please. Breakthrough action engages in a coordinated multi-channel approach on the field and the umbrella strategy with an overarching brand comprising all the included health topics. Also in community mobilization, community social behavior change, community capacity and sustainability. We address that aspect. They use mass media, radio, print, TV, and social media to support the change that is needed to improve positive behavior. They also use mobile and digital means, SMS and IBR, SMS communication, regular SMS communication. There's advocacy, targeting religious, traditional, and opinion leaders, and the provider behavioral change also. There's a particular program, the radio program called Albinishirin Ku, I think, which translates to I wish you well. I look out for your well-being, kind of, in Abishiniku is Hausa. Is one of their major programs where they send messages to the population. Next slide, please. Where do we work in Nigeria? Breakthrough actions programs are in 11 states of the federation, and you will see them on the screen. But to support our own research, breakthrough research, we implements the study in Kebbi, Sokoto, and Zamfara state. Because the main objective of our research, ab initio, is to compare what we call integrated programs, where all the health domains have their own intervention and messages. That's in Kebbi and Sokoto, to compare the results with the malaria-only, what you could call monolithic intervention area. This is perhaps one of the first place generally in the world that this comparison is being made. So in summary, our study covers Kebbi, Sokoto, and Zamfara states. Next slide, please.
Okay, thank you, Dele, and thank you for.
Okay, good. I wanted to hand over to Paul Hutchinson. I tell you, you will enjoy listening to the presentation. Over to you, Paul.
All right, thank you, Dele, and thank you, Foye. So as Dele was saying, I'm going to talk now about some of the work that we've been doing with the Behavioral Sentinel Surveillance Survey and how we're using that data to inform breakthrough action programming. So as people probably know, Nigeria currently has one of the highest fertility rates in the world, with the Northwest region experiencing the highest rates. According to the 2018 NDHS, the total fertility rate in the Northwest of the country is approximately 6.6 live births per woman, and women 40 to 49 years old average approximately 8.3 births in their reproductive lifetimes. This high fertility situation impacts maternal mortality. Nigeria currently has more maternal deaths annually than any other country in the world and has the 4th highest maternal mortality ratio. Unsurprisingly, only 6.2% of married women in the Northwest are currently using any form of modern contraception, and the majority of married women, 68.7%, report no need for family planning for either spacing or limiting. So in this context, Breakthrough Action conducted formative research to help design their programming over the life of the project. And some of their key findings were that religious and traditional beliefs are important, and perceptions of God's will influence fertility and fertility decisions. There is evidence that the use of modern contraceptive methods for childbirth spacing is increasing, but it's often still done in secret, and traditional methods are also commonly used. There's also evidence that many women would like to use modern contraception but are denied permission by their husband. And aside from issues of permission, there's a lack of spousal communication about contraception, which likely further inhibits planning for pregnancy. So now I'm going to talk a little bit about the BSS, just to provide you a little bit of background. And the BSS was designed to measure change across time in malaria, family planning, and MNCH behaviors and ideations. And the main population for this study that we're talking about today are women with a child under the age of 2 years. And this postpartum period corresponds to one of the key life stages focused on by Breakthrough Action, as Dele was showing in the earlier slide. We collected data in all 3 states, Kebbi, Sokoto, and Zamfara, but the data are only representative of BA program areas and not the states themselves. The study is cross-sectional to provide estimates of prevalence of behaviors and ideations over time. We use repeated cross-sections of women with a recently completed pregnancy at 3 points in time: baseline, midline, and endline. But we're presenting only baseline results today since we have yet to conduct the midline. As described by Dele, there is a quasi-experimental component in the sense that we are comparing geographies with integrated programming with those with vertical programming. So 2 states, Kebbi and Sokoto, are receiving integrated programming with family planning messaging, while Zamfara is not. There is also a dose response component in the sense that Breakthrough Action is implementing 2 types of programming, integrated programming: high dose integrated and standard dose integrated. We have a random sample of 3,043 women with a completed pregnancy in the past 2 years. That's our analysis sample. And there are 36 wards per survey domain for a total of 108 survey wards. And as I said, women were randomly selected. And in the presentation today, we are going to present univariate and bivariate analyses by state, by wealth, by education, and by ideational factor. And then we're also going to present mixed effects logistic regression results in which we test for the influence of different ideational factors on contraceptive use and other family planning outcomes. And then we model the impacts of shifting those ideational factors. So this is the theory of strategic communication and behavior change upon which Breakthrough Action activities are based. And it posits a pathway from exposure to communication activities here on the left. In this case, the mass media, advocacy, and community activities of Breakthrough Action through 3 ideational domains and 9 ideational subdomains, leading to changes in intentions and behaviors. And so survey questions in our household survey were intended to measure as many of these domains as possible. And we tried to maximize the number of ideational factors for which we collected data without risking respondent fatigue. The questionnaire was developed jointly with Breakthrough Action and with the input of outside experts. A lot of questions came from previous survey work that we've done in previous projects or that were in the DHS. And we prioritized questions based on their importance programmatically. So in terms of questions, here are our family planning ideational metrics. In terms of questions, we tried to have a question regarding contraception for each of the specific domains or subdomains over here. So for example, for knowledge, we asked questions such as, what are the benefits of contraception for a woman? And we asked questions such as, or agreement with statements such as, side effects from using contraception are normal and usually go away within a few months. Similarly, we asked about contraceptive myths and agreement with statements such as contraceptives can cause cancer and women who use contraceptives may become promiscuous. And then we coded the data for analysis as those who provided correct answers or pro-contraception answers versus those who did not. And you can see we continued on across the various subdomains. Importantly, we asked about social influences such as who decides if you use a contraceptive method, and besides yourself, who influences your decision to use family planning. And so this framework gives us a fairly complete picture for assessing which factors are most influential for contraceptive outcomes. So in terms of the presentation today, we are looking at programmatic questions across 6 areas. So specifically, we want to know about behavioral patterns. What percentage of women are using modern contraception? And what are the key behavioral patterns by geography or by socio-demographic characteristics? We also want to know about knowledge and beliefs. Are respondents aware of different methods of contraception and their benefits? Are certain myths held by respondents that could impede progress? And do people approve of family planning? We're asking about barriers, and specifically about both demand side and supply side factors which could augment or impede the uptake of contraceptive services. We ask about social influences and decision making. So how do contraceptive decisions get made in households, and who else influences women's contraceptive use? Then we'll look at ideational relationships. So how important are the individual components of the theory of strategic communication for contraceptive use? And which ideations should SBC programs target to maximize impact? And then finally, we'll look at what is the potential impact of SBC programs to spur behavior change in this context. So in our sample, 13.3% of the women were currently using a method of modern contraception. And you can see that there were variations across states ranging from 9.1% of women in Kebbi to 15.2% of women in Zamfara. And there were clear inequities in contraceptive use. In fact, a 4.6-fold difference in use between the wealthiest and the poorest. And you can see that this pattern was evident across all 3 states. These inequities were also mirrored by education levels. Again, we see a 4.5-fold difference in contraceptive use between women with a secondary or higher education relative to those with no education. We also looked at patterns in intentions to use modern contraception in the future. And keep in mind that we have a sample of postpartum women, and encouraging postpartum family planning is a key programmatic priority for breakthrough action. However, in this sample, contraceptive intentions appear to be fairly low. Only 14.7% of the sample of postpartum women intend to begin using contraception in the next 6 months. And again, we see inequities or differences across wealth quintiles and education levels. So we've also looked at various indicators by geography to see if there are any clear patterns. So here are our 3 states, Sokoto, Kebbi, and Zamfara. And the white areas represent areas where breakthrough action is not working, so we didn't sample there. And we've categorized LGAs by what percentage of women engage in a specific behavior. So red is less than 10% prevalence, and then it ranges to the bright green, which is 40% prevalence or more. And you can see that there are clear variations. Kebbi appears to have the lowest contraceptive prevalence rate, and that is almost universal across the state. The other 2 states show a bit more variation, having both good performing areas and poor performing areas, but overall showing both cross-state and within-state variations. We note that discussions with husbands show a bit better performance, fewer red areas, but also not so much green. So discussions with husbands obviously are not that common. Finally, we look at approval of family planning because it's unlikely that contraceptive prevalence can be shifted much if people are strongly opposed to it. And you can see that there is a bit more green now, but keep in mind that green is only greater than 50% prevalence, and there are still pockets of red, meaning that less than 25% of women approve of contraception for birth spacing. So clearly, these are areas for breakthrough action work. We looked at contraceptive methods use among current users, and across all 3 states, injectables were the most commonly chosen method, followed by implants and daily pill. Notably, as you'll see, not many women reported using lactational amenorrhea method as a method of contraception. And I want to talk a little bit more about that. So in our sample, we note that only 8 women in the total sample of 3,000 women reported using the lactational amenorrhea method for contraception. And that's not 8%, that's 8 women in total. And this is in spite of the fact that LAM was explicitly described in the survey, and roughly 38% of women with a child under 6 months report that they were exclusively or fully breastfeeding that child. So they may be practicing LAM without actually considering it as a contraceptive method. And interestingly, while women who are exclusively breastfeeding may have a lower need for contraception, they actually appear more likely to be using contraception than women who are not exclusively breastfeeding. So we asked questions about why women were using modern contraception, and the principal reason was for spacing. As you can see, approximately 3/4 of users preferred to wait before having another child. And unsurprisingly, given that the average age of women in our sample was only 25 years, the desire to limit births was not commonly cited, by only about 14% in Kebbi and only about 5% in Sokoto. Many women, approximately a third, said that their partner wanted to use a method, which, as we'll see, aligns with what we will see about autonomy in decision-making. Government is the main provider of modern contraception, supplying approximately 80% of all methods. And government hospitals, as you can see here, were more commonly chosen in Zamfara than in Kebbi and Sokoto, while government PHCs were more commonly chosen in Kebbi. So we know that there are many benefits to spacing births, both for children and for women themselves. And so women were asked about the benefits of using contraception for both parties. And most women were able to identify positive benefits for both women and children. So only about 1 in 10 women in Kebbi and Zamfara were unable to identify any benefits. And nearly 1 in 5 women in Sokoto were unable to identify any benefits. The most commonly cited reason for using contraception was to ensure better growth for future children, followed by overall health and better nutrition and better survival chances. Women also cited non-health benefits. More than 1 in 5 mothers cited the ability to provide greater attention to children, as well as to provide better education and more opportunities. Again, the majority of women, more than 85%, were able to cite health benefits to the mother of using contraception. And the most commonly cited benefit was to give a woman an opportunity to rest after birth, cited by approximately 2/3 of women. Other commonly cited reasons were to ensure better health and nutrition, reduce pregnancy complications, and to promote beauty and youthfulness. Notably, only about 1 in 7 women cited reduction in unwanted pregnancies as a benefit. Similar to knowledge, we asked questions about common contraceptive myths. So in this sample, less than 1 in 3 women held contraceptive myths, such as agreement with the statement that use of contraceptives can make a woman permanently infertile, or contraceptives can cause cancer. So this, of course, is obviously a positive thing, that the prevalence of contraceptive myths is so low. As mentioned when discussing the theory of strategic communication, we asked questions about values, norms, self-efficacy, and beliefs, among other things. And notably here, almost 2/3 of women agreed that couples who use family planning have a better quality of life, and more than 2/3 agreed that it is important for couples to discuss family planning. Nonetheless, less than half of women approved of using contraception for birth spacing, and this is in spite of the majority of women being able to identify positive health benefits from using family planning. Self-efficacy did not appear to be very high. About half of women felt confident that they could convince their husbands to use contraception, and only about 1/3 felt confident that they could use contraception if their husband opposed. So we have self-reported reasons for not using contraception, and the #1 reason was fatalism. Specifically, that fertility outcomes were up to God, which was cited by about 1/3, by about 1/4 to 1/3 of women. Opposition was also commonly mentioned, both opposition by respondents and by their partners. And because this sample is within 2 years postpartum, it was commonly cited that women were not using contraception because they were breastfeeding. So even though women may not consider that they're using LAM as a contraceptive method, they do understand its inhibiting effect on the likelihood of pregnancy. And so similar to what we saw for contraceptive myths, non-use for fear of infertility or for fear of side effects were not principal reasons for non-use, nor was lack of awareness of methods. Supply side constraints such as cost of contraception or lack of access were cited by only a handful of women. We asked current users of family planning about obstacles that they had encountered in obtaining and using their current method, and the predominant reason was fear of partners knowing, so cited by about 27.9% of users. An additional 13.8% had a fear of parents or other relatives finding out. Here we did see some supply side issues. Stockouts at facilities and long waiting times were cited by many women, and about 1 in 10 women said that they had trouble leaving home or work to obtain a method. So in terms of social influences and decision making, a question was asked of women: who decides if you use a contraceptive method? Is it mainly your decision, mainly your partner's decision, or do you decide together? And only about 1 in 6 to 1 in 4 women are able to decide themselves about using family planning. And this is highest in Zamfara and lowest in Sokoto. Partners tend to have greater control than women themselves in Kebbi and Sokoto, 32% versus 23%, and 25% versus 17%, but not so in Zamfara. And the most common situation was joint decision-making, ranging from 45% of women in Kebbi to 58% of women in Sokoto. So we found that discussions with husbands about family planning related matters were relatively uncommon. Few couples talk about fertility goals. So approximately 1 in 20 women in Kebbi and 1 in 12 women in Zamfara have ever talked with their husband about the number of children to have. So having specific fertility goals appears rare, or if couples do have such goals, it does not appear that they communicate them to each other. More couples, but still few, discuss contraceptive use. So you can see that contraceptive discussions range from about 1 in 6 women in Kebbi and Sokoto to 1 in 4 women in Zamfara. But overall, discussions amongst couples do not appear to be the norm. So that being said, differences in outcomes between couples who discuss and couples who do not is quite stark. As you can see here, women who discuss family planning with their husbands are 3.3 times more likely to be using modern contraception, 2.7 times more likely to intend to start using contraception in the next 6 months, and 1.6 times more likely to approve of family planning for spacing. And keep in mind, this isn't necessarily a causal relationship. It may be that the couples who have these discussions are characteristically different from couples that don't, and these may influence their family planning outcomes in other ways. So we ran mixed effects logistic regression models controlling for a number of things: age, education, wealth, occupation, and state of residence. And our outcome variables were current modern contraceptive use and 2 key intermediate outcomes: discussions with husbands and approval of family planning. And these latter 2 were chosen because increased husbands' involvement in contraceptive decision-making is a key BA programmatic goal. And we chose approval because the sample indicates that many women believe that family planning is beneficial, and couples who use family planning have a better quality of life, and yet approval of family planning isn't very high. So we'd like to see which levers programs might use to help improve discussions and approval and ultimately contraceptive use. So looking first at ideational factors associated with modern contraceptive use, this figure presents predicted probabilities or estimates of the likelihood of a woman using modern contraception for those that have knowledge relative to those who don't, for those who feel confident that they can use family planning relative to those who don't, and so on. So we saw on the previous slide that women who discuss family planning with their husbands are 3.3 times more likely to use contraception than women who don't. And we can see other factors that are influential as well. So women who approve of family planning are 2.9 times more likely to be using family planning than women who don't. And that may seem rather obvious, but note that there are some women here who don't approve of family planning, and yet they are using it. Notably, social influences are important. Women who report that they are influenced by health providers are 1.4 times more likely to be using modern contraception, and women whose husbands influence their family planning decisions are also more likely, but this result is not statistically significant. So what is the message here? Ideational factors clearly matter, specifically discussions with husbands, approval, knowledge, and social influences. Looking next at discussions with husbands, we also see some important and interesting relationships. Again, approval of family planning is important. Women who approve of family planning are 2.6 times more likely to have discussions than women who don't approve of family planning. And we can't necessarily speculate about causality, since we don't know if approval led to discussions, or through discussions approval was developed, or if women who approve of family planning are more likely to initiate discussions. But clearly there's some relationship between approval and discussions. And in this case, we also see a positive influence of husbands. So women whose husbands influence their family planning decisions are 1.3 times more likely to discuss family planning. So husbands' influence in this case also matters. So we've seen that approval of family planning is strongly related to contraceptive use and discussions with husbands. So it might be interesting to look at factors associated with approval. So one key factor appears to be discussions with husbands, but we kind of knew that from earlier slides. So controlling for other factors, women who have discussed family planning with their husbands are 1.6 times more likely to approve of family planning. Knowledge also seems to matter. Women with higher knowledge are 10% more likely to approve of family planning. Women with fewer contraceptive myths are 1.3 times more likely. And you can see other ideational factors also influence approval of family planning. We also compared outcomes by how contraceptive decisions were made, by the woman alone, by the husband alone, or jointly. And by and large, we found that couples who make joint decisions have better outcomes. So relative to couples in which the husband decides alone, that's the blue here, women or couples that make decisions jointly are about 50% more likely to be using contraception. They're about 1.7 times more likely to discuss family planning, and they are 6 percentage points more likely to approve of family planning. So clearly there's a relationship between joint decision making and better family planning outcomes. So making use of the regression models that we just referenced, we looked at what could potentially happen if breakthrough action achieved a world of perfect knowledge or perfect ideation. So if women had perfect knowledge of the benefits of contraception, held no contraceptive myths, felt fully confident that they could get and use family planning, approved of family planning, and had positive social influence. So these are the adjusted likelihoods of our 3 family planning outcomes: contraceptive use, discussions of family planning with husbands, and approval of family planning. Now suppose we had a world of ideal knowledge. Everyone knows the health benefits of contraception, and no one believes any contraceptive myths. Overall, that would increase the percentage of women using modern contraception by about 25%, from 13.4% to 16.8%. It would increase family planning discussions slightly from 22.3 to 24.4%, and increase contraceptive approval by a sizable 43.2 to 58.1%. Now suppose if all cognitive factors were positive, so every woman approved of family planning and had favorable family planning norms and so on, each of these indicators would increase even more. And we could see the same thing for perfect self-efficacy if every woman felt confident to use modern contraception. And so now suppose we had perfect ideation. Every woman is confident, all norms are favorable, there are no myths, and all women have supportive husbands. In that scenario, overall contraceptive use would increase to 63.6% of women. More than 2/3 of women would discuss family planning with their husbands, and approval of family planning would be nearly universal. So what is the takeaway? So if SBC programs could succeed in changing these ideational factors by whatever means, a whole host of family planning indicators would improve. So now moving to programmatic implications from this analysis. So we saw that there was low and inequitable modern contraceptive use in the study areas. And so the vast majority of women are not currently using modern contraception, and there's low approval. And the common reasons for this are fatalism, spousal opposition, and breastfeeding. We found that most ideations across cognitive, social, and emotional domains are associated with a wide range of family planning outcomes for SBC programs to target in their activities. We also noticed that there should be improved social acceptance, or a focus on improving social acceptance, dispelling myths, and improving overall approval of family planning. So SBC programs, Breakthrough Action, must work on improving social acceptance of family planning and dispelling myths such as contraception causes cancer or infertilities. And in this pursuit, health providers will play an important role. We also note that improved knowledge and supportive beliefs could also help build positive perceptions of contraception and improve respondent approval of family planning. Two other programmatic implications: we've found that spousal support is critical for contraceptive use. And so SBC programs could maximize impact by engaging spouses in promotional activities. Clearly, spouses play an outsized role in family planning decisions, and their support is critical for uptake, particularly through joint decision-making. But more research is needed to better understand male ideations in order to target SBC programs for this key stakeholder group. And as we saw in the last set of graphs, SBC has the potential to substantially improve family planning outcomes. And the simulations that we showed suggest that better knowledge of family planning benefits and more accurate risk perceptions would notably impact a range of family planning outcomes, with the largest effects coming from increased respondent approval and couples collaboration. Simulation also suggested that the most sizable impacts come from improved cognition, such as beliefs and values, emotional factors such as self-efficacy, and social spousal support factors. So now I want to turn it back over to Dele to talk about what's next and future steps.
Thank you, Paul. I already said it that we're going to enjoy the presentation. Having done all of this, you know, this presentation is one of 7 health areas in which we have presented this webinar. There's going to be another one on inequalities soon. But on this level, the next steps, and which we have always been doing, is to conduct BSS analysis to inform SBC program adaptation and scale up in Nigeria. We'll continue to do this from our data. We'll prepare manuscript. We've prepared a number of manuscripts, and that are still preparation is still ongoing, and then lots of research briefs. You will see them on our website, which links will be shared with you soon, even on the chat, and also slide decks to disseminate this result to the wider audience. We have planned and are just waiting for time, for the appropriate time to begin the BSS midline survey, which we would have concluded, but it's being delayed due to COVID-19. We'll continue to present BSS results by specific health areas, not only in these concluding webinars, but to targeted audience, for instance, IP or community of practice that will now normally be interested in specific areas of the result. For instance, we were speaking to the National Malaria Elimination Program group in Nigeria today with the malaria results. So if you think that we'll be able to speak to your programs, please feel free to get in touch with us, and we'll collaborate in presenting this result. The full result is also on the web. Next slide, please. And it's a trove of evidence, data, and information. I think individuals should just go to the area that speaks to their own program. Also, again, that's also on the net. This family planning webinar is the 7th, I think, of the series that began in June 11, and the next one is October 7, is on the inequalities or iniquities, if you like, which Paul already signified that was noted that exists, not only the data, but in the publication. This is a cross-cutting kind of thing, a kind of health determinant, and I want to invite every one of you also to come and participate in this webinar in October 7. Next slide, please. Our future work, this baseline result is the first step for assessing the effectiveness and cost benefits of integrated versus malaria-only SBC program in Nigeria. Like I said, we will continue to advance on this exploration in a midline and an endline wave of study. And it highlights ideation and behaviors during this baseline period to inform SBC programming, scale up, and adaptation, particularly the programming that Breakthrough Action is actively doing on the field. And it presents new additional metrics across maternal newborn child health and nutrition, and then family planning and malaria, as we have presented today. And then it quantify their relationship with behavioral outcomes to test behavioral change theories. And then it links BSS results with routine program data of health or health facility records to examine the impact of supply and then demand side factors on service. This is an area that we are still looking to explore very well, because it will help us to see the impact of the work that is being done in behavioral modulation in healthcare behavior. Next slide, please. Finally, I want to appreciate the project team. What we have had, there are people who are working very hard in the background to bring this result out, and they implement the state-of-the-art kind of scientific methods to make sure that we get hardcore evidence. The Paul Hutchinson presented to you now is our principal investigator in the University of Tulane. Paul Hilt, again, is our principal investigator from Population Council in Washington. Emily White Johansson, I introduced earlier, is our chief of party and the director of research. Elizabeth Omoluabi and Akani Akinyemi, both of them are in CRED. They participated in data collection. They in fact implemented the data collection activity with state-of-the-art technological, technology that brought a lot of validation and quality into the data. We have Dominic Makers, who is the University of Tulane, working in the engine room. Udo Chizum and Naba, also, like I told you, research coordinator in BR Nigeria, and Stella Babalala of Johns Hopkins University also contributed a lot into the design and the perspective of this study. We want to acknowledge my colleague in Breakthrough Action, Ian Tweedy, who is the chief of party in Breakthrough Action, Matthew Oko, also in Breakthrough Action, and then Shitu Abdu Agui of Breakthrough Action. He is already in. Is already on in this webinar. We will have heard from him a little bit about the program and implication of this result from BA's perspective. So thank you, everyone. I think I should hand over to Foyeke to round up and also support the question and answer and discussion period. We have Paul Hutchins and Paul Hewitt also, who may be speaking to some of the questions that you may ask. Thank you.
Yeah, thank you so very much, Dele. Thank you to Paul for, you know, taking us through that very engaging presentation, and, you know, the very granular level analysis of the types of levers that programs can pull, especially social behavior change programs, to get us to the kinds of outcomes that we're all looking to see more broadly. There are a number of questions in the chat box, and I'm glad to see that many of them have been responded to in real time. Thank you, Emily, for leading that. However, I see that there was one or two. Maybe we can quickly talk about them. We have about 3 minutes or so left. There's a question around breastfeeding versus LAM. So I guess there's been a couple of conversations on the chat box related to that, but I wanted to flag a comment that Anne made about the breastfeeding reason that women were given possibly being a little more complex than LAM, because they may have fear of side effects of methods, of contraceptive methods on breastfeeding. Or on the child through breast milk. So that sort of, those are some valid thinking that might go into maybe thinking through some additional questions in the midline assessment that could help us unpack, you know, that variation between stating breastfeeding as understanding that breastfeeding can help to reduce the incidence of pregnancy, but not necessarily considering it as a family planning method. So thank you very much for that. I just wanted to highlight that. I don't know if maybe Paul has any additional thoughts, but maybe quickly related to that.
No, I think that's a very important point. I mean, the one limitation of our survey is that we can only go so far into analyzing certain issues because it's such a broad survey. We're covering so many things: MNCH, family planning, malaria, and other things. And so we already had a fairly long questionnaire. I think that this is something that we should definitely look at a little bit more in depth, but our questionnaire was long, and so we couldn't go into as much depth on every issue as we would have hoped. But yeah, I certainly think that this is an area where we would warrant further exploration.
Yeah, I agree with that. It's always a trade-off between having a very long questionnaire and risking fatigue and really getting everything that you want in there. But, you know, there might be opportunity for one or two, or maybe additional qualitative analysis.
Right.
So there's also the question around whether we have shared these results with state officials from Kebbi, Sokoto, and Zamfara. So just to say that, yes, that is and continues to be the plan. So there's state-specific research briefs that have been created, and some of them have actually been translated even to local languages so that we're able to share with a broader range of stakeholders. COVID was one of the biggest barriers to having, in-depth face-to-face conversations with state, but understanding that Breakthrough Action has existing relationships within those states, results are already started to brief state-specific briefs that have been shared. Conversations will continue to happen, and every opportunity that we Breakthrough Research gets to have those sessions, we will take. There is another question in the Q&A, and I'm really just trying to oh God, there's quite a number in the chat box by now. There's a question in the Q&A. Can BA talk about what they have been able to do with these results? Dr. Shitu, do you want to talk to this very quickly in 1 minute?
Sure. Thank you for everyone for holding the fort. So these results actually, we've had various
Hello?
components to this study, results around the malaria components of the work that Breakthrough Action does in the States. Now we're keenly looking at the findings of the BSS and looking to see how we can use the results, looking at areas where we need to put more focus and more emphasis on in terms of messaging, and also areas where we need to engage more stakeholders around in these communities around these priority behaviors. Sure, as soon as we're back in the field after the whole COVID-19 pause that we've had, we'll definitely be looking to implement some of the new ideas we have that have emanated from the findings of the breakthrough research studies. Thank you.
Yeah, thank you very much. I think one important point to make based on what Dr. Shitu said is, always useful to think about adapting messages and figuring out which additional factors, are more important to have, messaging around for certain populations than others. I think because there's slight variations by age and by location as well. So there's a question here about whether we asked any question about who, between the two, the man and the woman, initiated the conversation about FP or self-efficacy to initiate the conversation. Did we have something? I guess all of our questions were directed at women. I'm not sure if we asked who specifically initiated it. Paul, do you want to respond to that?
We only asked about whether such conversations were held and not specifically who initiated the conversation.
Yeah,
I think that would be an important question to add to the midline.
Yeah, and I think that's a very helpful one. And I think also to note that, like we said earlier on, exploring additional factors among men was something that we hadn't done. That's definitely another area. Okay, then let me see. Is there any work that BR is doing looking at attitudes or behaviors of healthcare workers in relation to FP attitudes or decision-making related to family planning or couple counseling on FP? So this question would be for Breakthrough Action because they're the ones leading the programming and implementation and not Breakthrough Research. Dr. Shitu, do you want to talk about your work with provider behavior related to contraceptives?
I'm sorry, I didn't get the full question, but with regard to our provider behavioral work, our PBC work is largely focused on guidelines among providers and also around care buckets. We do address issues around PPFP as part of the care that pregnant women receive when they deliver at health facilities, and also the kind of methods they can take before they leave the hospital if they do deliver at a health facility to space births for at least 2 years before the next birth. One thing that actually came out from this study was the fact
Yeah, so I don't know if it's
that
just
a lot of women consider breastfeeding a reason contraception, but that's also one of the myths that we'll be looking to see to work more on. Because
please go on. We can hear you now.
Yeah, I'll just say one of the things that came out from this study was a lot of women still consider breastfeeding a barrier to use of contraception, and that's one myth that we'll definitely be taking a closer look at to address with the populations we work with in the various intervention states. Again, just to strengthen opportunities for PPFP and women getting methods before they leave the health facility, if they deliver at the health facility.
Okay, thank you very much. And I guess just to add to that and then take the very last question is, there's also the theme around respectful care overall that Breakthrough Action is focusing on. And I think when Paul was making the presentation, there was that point around, ideations around, a choice of location to get family planning as a result of whether women perceived they were going to get either quality care or respectful care or something like that. So there's one question here, and I think this will still be Dr. Shitu. So earlier on in the presentation, Paul mentioned that there was 2 types of integration. There was a standard dose, and then there was the intensive dose or something. So someone wants us to explain the difference between the 2 types of integration mentioned in the presentation.
Okay, I'm not sure exactly that we have 2 types of integration. We do have for the intervention, breakthrough action intervention, we have the integrated states currently, and we have states where we're implementing vertical SBC interventions. And Breakthrough Research is conducting this study in 2 integrated states, Sokoto and Kebbi. where we have integrated SBC interventions covering MNCH, nutrition, malaria, and then comparing with outcomes in the vertical state, which is Zamfara state, where we're implementing only malaria SBC interventions. So those are actually the two models, approaches we have. We don't have two types of integration, unless I didn't understand the question very well.
Yeah, so I think maybe the word integration might not have been the right one to use, maybe, but I guess the variation in the exposure to dosaging, sort of dosing of the messages in itself. So there I think there's that mix of methods, and then there's also the variation in exposure to dosing. I think that's what the question was about. So there's a comment here about the other reason women don't often start family planning in postpartum is that they wait for menses to come back. There may also be some probing about social norms around postpartum sexual abstinence and possible stigma associated with the use of FP in the first year postpartum. This is common in Liberia and Benin and may also exist in northern Nigeria. Yeah, thank you so much for those very salient points. I think we're leaving here with quite a number of interesting ideas as to, you know, what's feasible within the existing survey load that may be very helpful questions to ask to be able to dig deeper into some of these additional gray areas that we found in the baseline. So just to say thank you all so very much. We already short our time by 7 minutes and we still have quite a substantial number of people on the call. So really thank you for your engagement. Thank you for your questions. Thank you for, you know, this participation and all of the and the questions. I think the link to the full report was put in the chat box. If you haven't yet hit the link, please do so that you can download the full reports. I think a link to previous webinars as well as research briefs has also been put in the chat box. Contact details of our breakthrough research colleagues are also in the chat box. So if you'd like to follow up on anything, for example, the question around doing an additional analysis around age, you know, that would be very great. So they're asking if we would share the presentation. Sherry, I think a post-webinar email goes out, right, with some of this information.
Correct. So we'll have a link to the presentation and the recordings in there.
Exactly. So you would get the link to the webinar as well as the slides. So thank you again so very much. Like Daily did highlight, there's one more webinar on October 7th, which would really be interesting to see how the patterns of inequality across the different health areas. So this will be cross-cutting and not necessarily related to just family planning. So I have a sense many of us might be interested in that as well, and would strongly encourage us to make the time to attend. Thank you again so very much. This has been very engaging. So it's over from me. I don't know if Dele has any last words or Paul has any last words. Thank you again.
Except if Paul wants to have the last word, I think I've spoken enough today.
No, if people have specific questions that they would like to discuss further, we have your contact information, and we'll provide our contact information as well, so people can reach out to us for additional questions about the work that we've been presenting today.
And I just want to thank BA and all the team for a great presentation. Thanks, everyone.